So dear postgraduates, so please pay a little more attention for today's talk, one of the very important topic of the public interest. So how to treat hypertensives? So hypertension in India, which is it of growing concern. So a lot of the people in India are the hypertensives. So according to the India study, so nearly 38 crores of Indians are having the hypertension. So that means a very, very big problem in India to face it is how to manage the hypertension. So why is it of growing concern? It is increasing in the young population. So there is a high sympathetic overdrive. The stress related hypertension in the very young population. And we have a lot of the drugs in our hand. And still we don't know what is the right choice of the drug for that particular person. So that also matters a lot to avoid the long-term complications. So this is 1 in 5 or today maybe 1 in 4 young adults in India has the high blood pressure. So 10 to 30% of the young Indian population suffers from the hypertension. So the most important causes are the mental stress, obesity, faulty food habits, excess alcoholism, sleeplessness, and also smoking. So these are the risk factors for the hypertension in the young Indians. If you see all the risk factors, so the one risk factor is the smoking, and then the extra salt in the diet. So last class we discussed about the salt intake, 2 grams per day, and the lack of the adequate sleep. We also discussed about the sleep. So one should sleep for more than 7 hours a day, not more than 8 hours. Mental stress is equally important. And excess alcohol consumption, of course overweight and the obesity, and most important is the sedentary lifestyle. So if you see, most of our people are having these risk factors to get the hypertension. So if you take these risk factors to apply to ourselves, so we are all sedentary lifestyle, we are all overweight or obese, lot of mental stress, and extra salt in the diet is there in our breakfast, our lunch and dinner, etc. And of course, a good sleep is also lacking in most of our population, maybe of several reasons. Even though you are not a smoker, even though you are not in heavy alcohol consumption, you see the other factors, we are all having the other risk factor. That is the reason to get the hypertension in Indian population much early. This is the role of the sympathetic overdrive in the hypertension. The stress is very, very important. It induces the neuroendocrine responses in either rapid or a long-term manner. So sympathetic activation is very important. So not only the sympathetic nervous system, so hypothalamic pituitary adrenocortical axis, unhealthy lifestyles, mental distress, so these all will elevate your blood pressure. So sympathetic activation increases the heart rate. You all know that when you are in a hurry, so definitely our heart rate will increase. It promotes the cardiac and the vascular alterations, contributing to the development of the major complications of the hypertension, such as the tachyarrhythmias, LVH, and increased arterial stiffening. Overweight and obesity, it is associated with both increased sympathetic nervous system activity and also the plasma norepinephrine levels. So this is the present scenario in Indian population. So all are for medications and for the surgical aspects, but no one is reaching to that lifestyle changes. But I think that lifestyle changes is much more important than your drugs or the surgery. So with the lifestyle changes alone, with a good dietary approach, with a good exercise approach, in reduction of your overweight, some yoga, some meditation, and all these things, lifestyle changes. So definitely we can escape the hypertension, we can escape the diabetes and also other parameters of your metabolic syndrome, including your fatty liver. So our stress should be not only on your pills or the surgery, but also to say something about our lifestyle changes. That matters a lot in the management of the chronic diseases like hypertension. So with this background, we will move on to the approach to the pharmacotherapy. So risk estimation and when to treat the hypertension. Not all hypertensives are having the same risk. For example, if you take a 60-year-old hypertensive, age 60 years, hypertensive, but no other comorbidities, and the lifespan will be good. On the other hand, if the age is 30 years and is an hypertensive or a diabetic, a smoker, obese, sedentary lifestyle, and obviously this fellow will get lot of the complications in the near future. So what are all the complications are directly proportional to the age of the individual and also your comorbidities and also the how you get treated with medications, and of course lifestyle measures are also very, very important to control the blood pressure and keep the blood pressure at your target levels. So you have to initiate the pharmacotherapy not in all the hypertensive individuals, provided if the hypertension is in the stage 1 with your 140/90. So obviously your non-pharmacological management also will be sufficient to reduce the blood pressure to your normal levels. On the other hand, on the initial visit, if the blood pressure is 200/110, so definitely have to start the medications. So we have the lot of the antihypertensive medications, so ranging from your A, B, C, D and also other drugs like ACE or ARB, beta blockers, calcium channel blockers, diuretics, alpha blockers, central acting drugs, etc. So the choice of the antihypertensive varies from the person to the person. If the person is a diabetic and hypertensive, so your choice should be either ACE or ARB. If the patient is if the person is not, we should not call the hypertension as a patient, but as a person of the hypertension has the idiopathic conditions. So obviously your choice of the antihypertensive is a diuretic. In the same way, when the fellows is the renal hypertension, renal parenchymal hypertension with the creatinine level is about 5 and 6 and the blood pressure of 180/100, and obviously your choice is the loop diuretic plus calcium channel blockers or plus alpha blockers and etc. So compelling indications, yes, if the person is an hypertensive and also IHD, so the beta blockers are the compelling indication. In the same way, hypertensive, LVH, heart failure, so again the beta blockers are the compelling indications. So it is not a difficult one to initiate the management of antihypertensive medication, but what is more important for us as a physicians is escalating the treatment. So each and every visit you check the blood pressure, you say whether the patient is on target or not on target. If the person is not on target, what are the reasons for his poor control of the blood pressure? Is it the poor compliance or more salty diet or less exercise or less sleep pattern, etc., and then act accordingly. So escalating the management is very, very important. In the next visits, so definitely the blood pressure should come down to your target blood pressure of maybe 120/80 or 130/85. Timing of the therapy, most of the antihypertensive medications will give on the morning time after the breakfast, and sometimes when the fellow is getting the 3 or the 4 molecules, so better to give 1 molecule at the evening time so that early morning surge of the BP will be reduced and there won't be any ischemic attacks in the early hours of the day. If the person is getting 3 or 4 antihypertensive medications, providing 1 antihypertensive medication at the bedtime will definitely give you a dipping of the blood pressure during the sleep times and also to avoid the early morning surge of the blood pressure. So how long should we go? So 99.9% of the population times all the hypertension should get the lifelong management, and very few people will have a secondary hypertension. Suppose if you detect the secondary hypertension, so definitely if you treat that condition like your pheochromocytoma or renal artery stenosis or coarctation of the aorta, etc. So under surgical management, so definitely this person will become normotensive and lifelong treatment is not necessary. But this is not the story in about 99% of the population. So 99% of the population is essential hypertension, so they should get a lifelong management. Of course, if the person is obese and hypertensive, if they lose the weight with your terzepatide or etc. and etc., so definitely you can, if they achieve the normal body weight, and so obviously the blood pressure also will come down. So these are obesity induced hypertension can be reduced or they become the normotensive once they lose the excess weight. But otherwise most of the people they require lifelong management. So challenges in the sustaining targets. So every case is a challenge for us, because today you are seeing an hypertensive individual and the day after tomorrow or after 2 years or 3 years he will become a hypertensive plus. Sometimes maybe hypertension associated target organ damage with your LVH or with proteinuria or elevated creatinine levels or hypertensive retinopathy or hypertensive peripheral vascular disease or CVA or TIA, unstable angina or acute myocardial infarction. So these are all very, very, very common in our hypertensive individuals. So even though he is an hypertensive today, if you don't control the hypertension very effectively, and obviously it becomes a big challenge for us Otherwise, so these people will have very pure quality of the life and ultimately they die prematurely. So in the last class, I already told you that once the fellow is in hypertensive, he is losing the lifespan of nearly 3 to 5 years. Suppose if the person is a hypertensive with the target organ damage, and definitely the lifespan will be much reduced because of the target organ failures. So this also I showed you last class. A President Roosevelt, he was the US president. He died of hemorrhagic stroke. So when he died in 1945, his blood pressure was 350 by 195. So before the 1945, the high blood pressure was considered as a physiological phenomenon. So as age increases, the blood pressure will increase. Once under your stress, the blood pressure will increase. When you are not having the good sleep, again your blood pressure may rise. So they thought that these are all the physiological mechanism until Roosevelt, US president, died of a hemorrhagic stroke. And later they thought that no, we should not think this as a physiological one. Some pathology is also associated with it. So we always should keep the blood pressure at the target levels with some means. That means maybe your non-pharmacological management or the pharmacological management. So this is the very important lesson the world has learned after the death of the Roosevelt to start antihypertensive medications in all the hypertensive individuals. So this is the history of the antihypertensive medications. So he died in 45. So the first antihypertensive medication, mostly in the after his death, maybe 50, reserpine. So it's a very important molecule. That's our Indian native medication, the reserpine, and then the diuretics, they entered into the market, and then the methyl dopa, hydralazine, diuretics like hydrochlorothiazide. So they started with the sulfonamides. Sulfonamides also causes the hypertension. So they thought that in the people with high blood pressure, they used to give the sulfonamides. So sulfonamides will have a lot of the side effects in them. And finally, the scientists, they derived the hydrochlorothiazide from the sulfonamides. So that's how the hydrochlorothiazide derived from the sulfonamides. So then you have the beta blockers, then the verapamil, that's the calcium channel blocker, then the calcium antagonists, other antagonists like your amlodipine, cilindipine, felodipine, benidipine, and then the alpha blockers like the prazosin. It's a very useful drug but causes the postural hypotension and has an advantage of uricogenic effect. ACE inhibitors, excellent drugs that entered into the market way back in 80s. You have the ramipril, you have the enalapril, lisinopril, etc. And then you have the ARBs. So again, you have losartan, telmisartan, azilsartan, olbisartan, etc. And then you have the direct renin inhibitor, lalskirin. So these are the how now we are very fortunate. We are very, very fortunate that we have very good number of the antihypertensive medications in our hand, unlike our forefathers. Okay. So the treatment of the hypertension in the 40s and the 50s with the diet only. Some surgical mechanisms like your sympathectomy. So lumbodorsal sympathectomy and the splanchnicectomy, the side effect was hypertension. So they take an advantage of the side effect by following this surgery in the same way like minoxidil. So minoxidil is a vasodilator, but the side effect is hirsutism. So all the hair transplant surgeons, they take the advantage of the side effect of the minoxidil and they keep on using lot of the tons and tons and bottles of minoxidil for the hair growth. So here the medical, the pentoquine anti-malarial, so that also causes the hypertension. So most of the anti-malarials, they cause hypoglycemia. You all are familiar with that. So malaria therapy, so they cause hypoglycemia. Then in the same way, so they also cause hypertension. Rauwolfia serpentina, ganglion blockers, hydralazine, and later the thiazide diuretics. So no case of hypertension with a good renal function should be considered impossible to treat until proven otherwise. So that is the reason after a few years the hypertension was considered as a nephrological problem. So in India, hypertension means we think of more of the cardiology, but in the Western population, the hypertension is a part and parcel of the nephrological course. So nephrology, there is a nephrologist and the hypertensionologist, whereas in India, it's a part and parcel of the cardiology. But in fact, if you see the pathophysiology of the hypertension, so nephrologist role is much more than the cardiologist. Diuretics are the first group of the drugs to effectively reduce the hypertension without causing the undue adverse effects. The first group of the drugs to effectively reduce the hypertension without causing the undue adverse events. Sulfone is routinely used to treat the bacterial infections. Patients notice that they had their large diuresis after taking this medication. Then they taken the advantages. See the beauty of our ancestors, our earlier doctors. See William Schwartz. Administer sulfonamides to 3 patients with the heart failure. So heart failure with the preload, postload, afterload, lot of the fluid overload. So they need diuresis. Improved dramatically by using the sulfonamides. But Schwartz concluded that these medications were too toxic for prolonged or the routine use. So you can't use the sulfonamides for an heart failure population for 6 months or the 1 year. So they cause a lot of the side effects. So it was too toxic. So what to do? So fortunately, he spread this message to the Bayer, and Bayer modified the formula of the sulfonamide and developed the beautiful molecule, even very useful even today for us. That is chlorothiazide. From them, chlorothalidone. Okay, so relatively safe but effective diuretic. So that's how the new drugs have entered into the market from the 40s and the 50s and the 60s and the 70s. See, this is the beautiful slide show you a BP reductions of the 2 mm reduce the CV risk by 10%. Okay, so a lot of the people are there. There are a lot of the studies. So 2 mm reduction in the blood pressure, that to systolic blood pressure, you will have a 7% reduction in the risk of IHD mortality and also 10% reduction in the risk of the stroke mortality. If you see the BP reduction, so the more benefit for the brain when compared to the heart. Okay, so that is the reason the brain needs very, very potent antihypertensive medication. So what is the most potent antihypertensive medication? A, B, C, D, E, C, calcium channel blockers. They are very potent antihypertensive medications. That is the reason in all the neurology population, neurologists, their favorite drug is amlodipine or cilindipine, calcium channel blocker. Okay, for the cardiologists, they prefer more of ACE inhibitors, ARBs or the beta blockers. Okay. So the effect of the long-term modest reductions in the CV risk factors. See the 10% plus 10%, it is not 20%. 10% plus 10% is 45%. That is the beauty of the medicine. So if you reduce the 10% reduction in the blood pressure, and if you reduce the 10% reduction in your total cholesterol, so it should be less than the 200, LDL should be around 50, HDL should be more than 40 in the males and more than 50 in the females. Non-HDLC cholesterol should be less than 80 or less than 100. So these are the targets of your cholesterol management. Just reduce 10% of your blood pressure from 180 to maybe 172. From the 250 of your cholesterol, maybe only 10%, that means 25. Okay, so but you will get a cardiovascular benefit of 45%. Okay, so the 45% reduction in the cardiovascular diseases. So what are the goals of the therapy? The ultimate public health goal of the antihypertensive therapy is to reduce the cardiovascular and renal morbidity and the mortality. So a lot of the hypertensive individuals, they die in the hands of the cardiologist, whether they have a cardiovascular diseases or even the renal diseases also. Even the CKD population also, they die in the hands of the cardiologist because of your mortality, because of your hyperkalemia induced cardiac arrhythmias, or maybe your CKD induced premature atherosclerosis and acute myocardial infarctions and then sudden cardiac deaths. So the correct evidence suggests the target blood pressure less than 140 and the DBP diastolic less than 90 in all patients with uncomplicated hypertension. So even my goal is 120 by 80. Why 140? Maybe why not 120? So 120 by 80 should be your goal in all uncomplicated hypertension individuals, provided if they are not having any hypertensive symptoms like giddiness, etc. Since most persons with hypertension, especially those more than the 50 years of the age, will reach the diastolic blood pressure goal once the SBP goal is achieved, the primary focus should be on attaining the systolic blood pressure goal. So earlier, they thought that when the blood pressure is more in the 60-year-old fellow, when the systolic blood pressure is 160 or 140 and the diastolic is 80, they don't give much importance, because as age increases, your systolic blood pressure will increase. Now, at any age, systolic more than 140 is dangerous. So that means that is isolated systolic hypertension. Isolated systolic hypertension means SBP more than 140 with a normal diastolic blood pressure. Isolated diastolic blood pressure means diastolic blood pressure more than 90 with a normal systolic blood pressure. So hypertension in the current era. Treatment of hypertension is one of the medicine's major successes for the past 50 years. So you all should become a very, very good hypertensionologist. So by noting the hypertension, how to treat it, because a good success will be there in your hands. Lot of the drugs are there in your hand. You have a lot of the pathophysiological mechanisms to have the hypertension. A clear-cut understanding of the hypertension is possible nowadays, and you have the good drugs in your hand. So why don't you get the success? What is your success in hypertension? Keep the blood pressure at 120/80, not for today or tomorrow, as long as he lives. So unless you make the person normotensive for quite a long period, you cannot escape the complications. So the complications are directly proportional to the amount of the hypertension that. Advances in therapy provide the capacity to lower the BP in almost every patient. So every patient we can reduce the blood pressure to your target level of your 120/80. So from tomorrow onwards, you pay little more attention towards the hypertensive individuals. You take a proper history, you take the proper examination, you come to a reasonable diagnosis, whether it is essential hypertension or secondary hypertension, and get the appropriate investigations like your complete blood picture, complete urine examination, your renal profile, your lipid profile, your electrolytes, your thyroid profile, etc. And if the diabetic, HbA1c, and then treat accordingly with your good ARBs or with your calcium channel blockers or with your diuretics or maybe alpha blockers, etc. Because most of the people, they need a combination therapy. So single drug, a monotherapy is useful in hypertension, maybe 5 to 10% of the individuals only. In my practice, more than 90% of the individuals with hypertension, they need a combination drugs. Sometimes the 2 drugs, sometimes the 3 drugs, sometimes the 4 drugs, sometimes even the 5 drugs also needed to keep your target. So don't bother about the number of the medications you are prescribing, but give a lot of importance to your number of your blood pressure recordings. So your blood pressure recording should be 120/80, even at the cost of 3 drugs or the 4 drugs or 5 drugs, because keeping the person in the normotensive, you are avoiding the long-term complications and also you are giving good quality of the life. And however, this is the most important sentence of today's talk. Uncontrolled disease by all of us is rampant despite improved therapy. So this is the hypertension paradox. Why? Lot of people are there in the society with hypertension. We have a lot of very, very good drugs at a reasonable price. And you don't require any costly investigations like CT scan or PET scan or MRI to diagnose hypertension. But still, if you see the follow-up of these people, the blood pressure is always 160/100, 150/100, 140/90. No one will have the BP reading of 120/80. Why? So this is a very, very big important question. So you ask yourself, where I am wrong in not getting the target blood pressure in my patient. So then you think of, then you will know what are all the reasons for that poor control of the blood pressure in your own patient, and then correct them. Some of the reasons are yours and some of the reasons are them, and then finally you achieve your normotension in these populations. So why the reasons for this hypertension paradox? Because it's a silent disease. It's very difficult to treat a silent diseases. So in India, the persons will go to the hospital only when they are symptomatic. As long as they are asymptomatic, they don't go to the hospital. So this hypertension is a silent disease. You have to tell all these people that, see, this is a silent disease. You are discovered as a hypertensive on your opportunistic screening. From tomorrow onwards, you are an hypertensive. So definitely you need medication, even though you are not having any symptoms. If you don't control the blood pressure effectively, you are going to get this complication, that complication, etc., etc. So you have to educate the patient. Adherence is very important, and compliance is also very important. Adherence to your molecule. So what the molecule you are producing, you are giving, may be causing some side effects to him, and he may not treat it, continue it. Suppose you are starting with the sartan, he developed some cough, intractable cough. So probably, obviously, he thought that, so my cough is because of this drug. So to reduce my cough, better to stop the drug, because I am asymptomatic. All these days, I am asymptomatic. Now I am become the symptomatic because of this drug. The same thing, you know, a lot of the side effects of your antihypertensive medications, like pedal edema with your calcium channel blockers, or with your erectile dysfunction with your beta blockers, or bradycardia with your beta blockers, postural hypertension with your alpha blockers, electrolyte imbalance and leg cramps, etc., with your diuretics. Okay, so these are all the common side effects we often see day in and the day out. So you have to tell that patient that before he develops the side effects. You tell your patient, say I'm starting you with an amlodipine and you may get pedal edema. So that pedal edema you are going to get after 1 week or the 10 days or after 1 month is because of this medication. But don't discontinue this medication. Continue the medication till your next visit. Then we'll think of it, whether you have the very high pedal edema, etc., we change to some other drug. But don't give the diuretics for that pedal edema caused by the calcium channel blockers. Inadequate therapies, yes. So you have to improve your understanding about the hypertension. So you have to give very good medications to reach your normal tension. So pathogenesis remains unclear. So the essential hypertension, still 90% of the cause is not known. We have the different mechanisms. Maybe your fluid overload, maybe because of your renal origin, maybe because of RAS activity, maybe because of sympathetic nervous activity, maybe because of your tachycardia. So these are all some of the reasons for the hypertension. So that main exact cause in that particular person is very difficult to know. Persistent hypertension. See in society, definitely nowadays, every day, every year we are seeing more and more resistant hypertensions. So earlier the blood pressure on control is 1 drug or 2 drugs or 3 drugs. Now at least 40% of my patients, they are on the 3 or the 4 antihypertensive medications. So in a single word, they are resistant hypertension. So 3 antihypertensive medications, 1 should be a diuretic, or 4 hypertensive medications with good control. So they are resistant hypertension. Masked hypertension. So you have the white coat hypertension, they are lucky fellows. They have the hypertension inside the chamber and outside the chamber, they are normotensive. So they don't have any side effects, they don't have any chronic complications. But these are the very dangerous fellows, masked hypertension. They are normotensive in front of you, but they are having hypertension in the home, maybe because of the spouse factor, maybe because of the son factor, sunstroke, maybe because of the daughter stroke, or maybe in the office. So there are a lot of the things are there. So that could be the reason for their masked hypertension. These are the very dangerous. At least in society, 10 to 20% are having the masked hypertension. So unless we advise the home blood pressure management or ambulatory blood pressure management, it is very difficult to detect a masked hypertension in individuals. So thanks to the COVID, now every house is having 1 glucometer and 1 BP apparatus. So with that reading, we are getting a lot of the masked hypertension individuals. So when to treat hypertension? So this is the one case, a 50-year-old male, blood pressure 160 by 100. He smokes 10 cigarettes a day, BMI 25, waist circumference 100, is a non-diabetic. Total cholesterol 257, we should not say total cholesterol, it is a serum cholesterol 257, and FBS 110. So what is the working diagnosis? Okay, what are the ingredients here? Dyslipidemia.
More than 90.
Okay, waist circumference more than 90. Okay, here it is 100. Okay, one is obesity. BMI is also 25. So the normal is 23 for Indians, Southeast Asians. Okay, he is dyslipidemic. So cholesterol should be less than 200. Okay, is he a diabetic? Fasting blood sugar should be 100. Here it is 110. So 110 for the Western population. For Asians, again metabolic syndrome, it is 100. So 100 fasting blood sugar, cholesterol is more, waist circumference is more, and is in hypertensive. So definitely is in a stage of metabolic syndrome, even though not a diabetic. Diabetic means fasting blood sugar more than 126, PP blood sugar more than 200. Good. And also another important point here is not only a metabolic syndrome, but also more vascular reasons, vascular diseases are associated with smoking. Smoking will increase all the vascular diseases, premature atherosclerosis, etc. and etc. What are all? So, what advice you give to him? How to treat him? So, for the treatment again, 1, how to reach your blood pressure. Your target is 120 by 80. Okay. So, how to reach them? Blood pressure. What drug you prescribe? In a pre-diabetic, in a obese, hypertensive. Fast. You have only 4 classes, A, B, C, D. Which class you use? Use A.
Yes.
Okay, S or A or B use because it is already having a impaired fasting glucose. Okay, fine. So with that you can reach the hypertension part. So suppose if the person is not under control with your ACE or ARB, then you can add some other drug. Okay, some other drug could be a low dose of diuretic, or a 2.5 milligrams of amlodipine, or maybe 2.5 milligrams of bisoprolol, etc. That is the second choice. Okay. Then how to reduce your BMI from 25 to 23? Okay. Okay. So you are the right person to advise him how to reduce this BMI. Fine. So whatever the waist circumference, same. Once you reduce the BMI, obviously your waist circumference also will reduce. So whatever the cholesterol. What is your target cholesterol? Target is less than 200. So now it is 257. So don't be happy with the cholesterol alone. So get the lipid profile. Okay. So know how, what about his HDL, what about his LDL, what about his non-HDLC. So non-HDLC nothing but cholesterol minus HDL. So then act accordingly. But obviously in a metabolic syndrome fellow, what is the drug of choice to reduce the cholesterol? Statin. Statins. So which statin you use? So when you want to use, it is always rosuvastatin scores over the atorvastatin. So rosuvastatin. So how much you use? What is the dose of the rosuvastatin you use here? So rosuvastatin is divided into three groups. One is low intensity, medium intensity, and high intensity. Low intensity 5 milligrams of rosuvastatin or 10 milligrams of the atorvastatin. Medium intensity 10 to 20 milligrams. High intensity 20 to 40 milligrams. Okay. So in Indian population, there is no role of low intensity statins. That means 5 milligrams of the rosuvastatin and 10 milligrams of the atorvastatin not of any use in Indian population. So as you rightly said, 10 milligrams of the rosuvastatin is sufficient here. Maybe you can increase to 20 milligrams also. So what is the difference between medium intensity and high intensity? Medium intensity means that reduces the cholesterol by 30 to 40%. Okay. If it reduces up to 50%, 40 to 50%, it is high intensity statins. So beyond 50% is very difficult to reduce with the statins alone. You can add ezetimibe, or you can go for the bempedoic acid, or sometimes you can use the PCSK9 inhibitors like monoclonal antibodies. So that is how you have to control the cholesterol. But here, maybe 10 milligrams or 20 milligrams of rosuvastatin is sufficient. What about the fasting blood sugar? So how to control the fasting blood sugar? 110 to what is your target? 100. Need not be always the drugs. With simple dietary approach, your lifestyle measures, you can reach your target. Suppose if you want some drug to be added here, what drug you prescribe? So drug of choice for your metabolic syndrome is metformin. Metformin. So that is the insulin resistance. So what is the root cause of the metabolic syndrome? Insulin resistance. So insulin resistance is the cause for your diabetes, hypertension, dyslipidemia, obesity. So what is the drug which acts against the insulin resistance? Obviously metformin. So that's how you have to treat it. So as a good physician, so when you have such things, want to control it, how to control blood pressure, how to control the obesity, how to control the cholesterol, how to control the blood sugar. Here blood sugar with the diet approach. With cholesterol, maybe statin. With the weight circumference and BMI 25, again with your dietary approach, etc. And with the blood pressure, you need some drug. Okay? So that drug should be either a sartan or a prelude. Either ACE inhibitor or ARB, because he is also a metabolic syndrome, a vascular disease. Good. So will you treat this patient? Will you treat this patient? Yes, definitely. So here you should understand that treatment means how to treatment. Treatment means might not be always a pharmacological treatment. Sometimes it could be non-pharmacological management also. So definitely you have to treat it either with their drugs or with your lifestyle measures approach. Another case, a 64-year-old lady found to have high blood pressure at a routine check. Very common in our routine practice. Cholesterol 240, HDL 40. Past medical history, she is a known type 2 diabetes, but controlling with the diet alone. Drug history, none. Substance use history, non-smoker, occasional alcoholic, Saturday nights. Family history, hypertension and type 2 diabetes. So heart sounds are normal. Nil to suggest the secondary cause for the hypertension. There is no renal bruit or no thyroid, etc. ECG is the normal, no LVH. Urinalysis is the normal, no proteinuria or no CAS. Fundus is the normal, no no retinopathy, hypertensive retinopathy changes. So this is the BP. Systolic 147, 149 and the diastolic 95, 92, 96. Left arm is a similar. How will you manage this patient? So what is the working diagnosis here? So you should utter a word, postmenopausal woman, that carries a lot of respect as far as the vessels are concerned. So they are at high risk of getting the vascular diseases. Okay. So whenever a age more than the 55 or the 60, you utter a word of postmenopausal woman. That gives, you have to give a lot of respect to the menopause situation. So hypocalcemia, osteoporosis, so vascular protection. Okay, so that all happens to be right. Okay. Then
Hypertension.
good. This is the hypertension de novo. So you diagnosed hypertension today only. She was diagnosed as hypertension, not a moderate hypertension, high blood pressure. So that may be stage 2 or stage 3. Fine. And dyslipidemia. So hypertensive, postmenopausal, hypertensive, de novo, and then cholesterol. So cholesterol, two parameters here. One is good cholesterol is low and bad cholesterol is high. So cholesterol 240 but HDL is only 40. Suppose HDL 60 here, we are happy because good cholesterol is at high good level. So even though the bad cholesterol is a little bit higher, so that nullified and not much of vascular risk. But here a double vascular risk because of the high cholesterol and a low HDL. Good. And past medical history, she is a known type 2 diabetes. But fortunately under control with diet alone. Good. That is a social alcoholism, you can neglect it. You can, okay. But family history, so known hypertension, the type 2 diabetes. Okay. So anything you had in any added point in the examination? So there is no kidney involvement, there is no retina involvement, there is no causes for the secondary hypertension, and there is no LVH also. Okay, fine. So this is the, what is the stage of the hypertension? Stage 1 only. Stage 1 is 140 to 160 systolic and diastolic 90 to 100. So stage 1 hypertension. Okay. How will you manage this patient? She had the hypertension stage 1. She got the history of her diabetes. She got dyslipidemia and postmenopausal woman. So how will you manage? A lifestyle advice. Okay. Consider home blood pressure monitoring or ambulatory blood pressure monitoring. Establish a CV risk score. What about her risk of the cardiovascular disease? So is she at moderate risk or mild risk or severe risk? With this background. So postmenopausal, hypertension, diabetes, dyslipidemia. So we didn't know the BMI here. Suppose our BMI is 28. So that depends. So with this background, I think she is having a very good risk of vascular risk, not a mild risk, maybe moderate to severe risk. Start antihypertensive therapy with either ACE or ARB because she is a known diabetic. Okay. So your choice should be either ACE or ARB. So that's how we have to treat. These two cases will tell you so how to treat the hypertension from our patient's point of view. So keep in your view all the things and then you start with the proper medication. So not in all individuals. Suppose if the blood pressure is 140, same patient, same person. See here. So these are the values. 140 by 9 by 96, same. But if you see here, she is 30-year-old. Found to have the high blood pressure routine check. The cholesterol is 180, 160. HDL is 55. Past medical history, not a diabetic. Drug history, none. Non-alcoholic, non-smoker. No family history. No family history of premature atherosclerotic cardiovascular disease. So then what is your treatment? So then the treatment is lifestyle advice. Consider, establish a mild risk. Except the hypertension, she is not having anything X. Okay. So do you start treatment? No. Only with your lifestyle. You wait for some more time. You wait for 1 month or 2 months or 3 months and the next visit is see the blood pressure again. So she could be a normotensive. without any medication also. So this is the beauty of your understanding of the hypertension. Okay, so give the medication whom they require it and advise the lifestyle measures when the medication is not needed for that population. Okay, fine. Now initiating the pharmacotherapy. So started in individual with a diagnosed hypertension more than 140/90, in whom the lifestyle treatments have not been effective. In whom lifestyle treatments have not been effective. That means lifestyle measures are very, very important. If they are not effective, then you need a pharmacotherapy when the blood pressure is 140/90. Stage 1, already I told you that is 140/90. Settings where health core resources are highly limited, clinicians can extend the non-drug observation period in uncomplicated stage 1 hypertensive patients, provided there is no evidence for an increase in the blood pressure or the appearance of cardiovascular or the renal damage. That means target organ damage is not there. It is only type 1 diabetics, stage 1 hypertensives. So definitely you can advise lifestyle measures only. What about the stage 2? Stage 2 hypertension. Drug treatment should be preferably started immediately. So that means what you mean by stage 2? When the systolic is more than 160 and the diastolic is more than 100. That is stage 2. Stage 3 means more than 185, more than 110. So even at the stage 2, so require the medications immediately after your diagnosis without waiting to see the effects of the lifestyle changes. You advise the lifestyle changes. They are the complementary. Advise him about the role of the salt, role of the fruits, role of the sleep, role of the yoga, role of the meditation, role of the saturated fats, role of the non-saturated fats, unsaturated fats, role of the trans fats, etc. etc. You tell whatever all the knowledge you have about your dietary approach, your exercise, etc. etc. But definitely they need medication also along with your lifestyle measures once the pressure is in the stage 2. Stage 2. So drug treatment can also be started immediately in all hypertensive patients in whom, for logistical or other practical reasons, the practitioner believes it is necessary to achieve more rapid control of the blood pressure. The presence of other cardiovascular risk factors, moderate or high CV risk, should also accelerate the start of the hypertensive treatment. Suppose the person is stage 2 hypertension, also happens to be a diabetic or dyslipidemia or obese and a smoker. So obviously your CV risk is very high. High CV risk, you require more medications for them. So for patients older than the 80 years, the suggested threshold for starting the treatment at this level is 150/90. So for them, the systolic is 150, more than the 80 years of the age group. Less than the 80 years of the age group, it is 140/90. More than the 80 years, it is 150/90. So that also you should remember, because nowadays we are seeing more of the geriatric population. So last week I admitted one fellow aged 94 years. Okay. So today I admitted another fellow with 96 years. So now the geriatrics, you all should become like a geriatric physicians. Geriatric. In India, there is one medical college having MD Geriatrics, Madras Medical College. Like our MD Pediatrics, MD Internal Medicine, and also MD Geriatrics. So they see all the cases more than 60 years of the age group comes under the geriatric age group. I think nowadays even 70 you can say. Okay. So this is very important. So they respect their kidney function, they respect their brain activity, dementia, Alzheimer's, Parkinsonism, all these comes under this geriatric population. Now a lot of the metros, now geriatrics have entered into the corporate setup also. Even in the AIMS also there is a department, geriatrics. Now they started MD geriatrics. So hypertension, old concept, hypertension, treat with the drugs. Normal BP, ignore it. Is it right today? Don't ignore the normal BP. So identify the fellow who are at risk of getting the hypertension. Okay? Identify the individuals. So individual is obese, individual is a smoker, individual is having a lot of the stress and the strain, even though now the blood pressure is 120/80. So don't ignore it. So he is a potential candidate for future hypertension. So advise all the non-pharmacological management in him, so not to achieve hypertensive goal in the near future. So don't ignore even the normal blood pressure individuals also. So if you ignore the normal BP blood individual, so they will become the pre-hypertensives, and the pre-hypertensives will the hypertension. So conclusion, when to initiate the treatment and the risk. Untreated hypertension, reduce the life expectancy by 5 years. So you treat with any drug, you can increase the life expectancy. If you keep the blood pressure at higher level, so obviously the life expectancy will reduce. Lowering the BP reduce the risk of the severe morbidity and the mortality. Choice of the antihypertensive medications. This is a much debated topic. Compelling indications and contraindications based on the coexisting conditions. Okay. Suppose if the potassium levels are 5.5. So do you want to use the spironolactone in him? Obviously no. When the creatinine level is 6. So do you want to continue the ramipril or the telmisartan? Obviously no. So these are also very important. You know the indications and also the contraindications of that particular drug. So the patient is on the sartan, your patient is on the sartan. Okay. So his potassium level is 5. So do you add as a spironolactone in him, or a loop diuretic, or a thiazide diuretic? He needs a diuretic. Potassium level is 5. He is already on the sartan. Tell me sartan 40 mg. So what is your diuretic of choice at that juncture? So definitely not on spironolactone, because already the potassium level is 5. If you start the spironolactone, what will happen to these potassium levels? Increase. So more damage. So never, definitely no to the spironolactone. Okay. Yes, either to your diuretics like your loop diuretics or your hydrochlorothiazide or chlorothalidone. So depends on your GFR. So GFR is 25. So what is your diuretic of choice in them? The GFR is 25. Loop diuretics. Once the GFR is less than 30, you should change over to loop diuretics. Suppose GFR is 65. So what is your diuretic of choice? Potassium is 5, GFR is 65. Definitely not a spironolactone, not the Lasix, not the loop diuretics. So what diuretic you are leaving? Chlorothalidone or hydrochlorothiazide. That should be the answer. ఇంత స్లోగా చెప్తే పరీక్షలు పాస్ అవ్వరు. మడ్లుగా ఉండకూడదు. ఫస్ట్ మీకు ఇంట్స్ ఇస్తున్నాం కదా, ఇంట్స్ని క్యాచ్ చేసుకోవాలి, ఇమీడియట్గా చెప్పాలి. వెంటనే ఎగ్జామ్లో తెలిసిపోద్ది వీడు డల్ క్యాండిడేట్ అని పక్కకు మళ్ళీ ఇంకొకసారికి వెళ్ళిపోతాడు. సో దెన్ యూ లూజ్ ద ఎగ్జామ్. ఓకే. సో అండ్ హీఈస్ గివింగ్ ద హింట్స్, యూ హ్యావ్ టు యాక్సెప్ట్ ఇట్ అనమాట. యూ హ్యావ్ టు see, it is the most important to achieve the control of the blood pressure rather than fret over the choice of the antihypertensive medications. See, coronary artery disease and the stroke suggests that ACE inhibitors give benefits beyond the BP lowering for the CHD protection. So ACE inhibitors are ARBs. They give CHD protection, that is cardiovascular disease or coronary artery disease, etc. Okay, protection. So that is the reason ACE inhibitors or ARBs are called as cardioprotective drugs. Whereas calcium channel blockers give benefits beyond the BP lowering for the stroke protection. So that is the reason the favorite antihypertensive for neurologists is the calcium channel blockers. Whereas for the cardiologists, ACE or ARB or beta blockers. Okay. So what are the key points? Most have the similar efficacy. Marked differences between the drugs in the side effect profile. Tolerability may be influenced by the patient characteristics. Monotherapy will generate 30 to 40% response rates, not even the 30 to 40, maybe 10 to 20%. Most patients may require dual therapy or triple therapy or the quadruple therapy, especially our Indian population. We need more antihypertensive medications. What are the compelling indications? So these are the ACE. What are the compelling indications for the ACE? One is the diabetes. In all the HD and the cardiology postings, started with the ramipril 1.25 mg, Cardace 1.25 mg, 2.5 mg, etc. and etc. Then in the heart failure, your ACE or ARB or ARNI. In the nephropathy, proteinuria is there. So obviously your AS or ARBs. So these are the compelling indications. So heart failure, post myocardial infarction, type 1 or type 2 diabetes, nephropathy, your proteinuria, and second is stroke prevention. So what are the other possible indications? In the CKD, so as long as the creatinine level is at the level of 3.5 or the 4, but the nephrologists, good nephrologists, they use the ACE inhibitors even at the creatinine level of 4 or the 5 or the 6 also, because they have the dialysis facility on their side. But without the dialysis facility, so better to stop the ACE or ARBs when the creatinine level is more than 3 or 3.5. So what is the caution? Renal impairment. So always monitor the creatinine levels and the potassium levels. Those people are on ACE inhibitors or ARBs. What are the contraindications? Pregnancy is a big contraindication. So diuretics and ACE or ARBs are contraindicated in the pregnancy. You can safely use calcium channel blockers and the beta blockers or the alpha blockers or combined alpha and beta blockers like labetalol. Side effects, dry irritating cough, angioneurotic edema, that is also very common with the ACE or ARBs. Hyperkalemia, that already we discussed, and reversible decline in the renal function in some cases. ARB, same as them, almost the same. CCBs, calcium channel blockers. You have the dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. So compelling indications, elderly. So elderly hypertensives or isolated systolic hypertension. The two drugs are drugs of choice. One is calcium channel blocker, the second one is diuretic. Suppose 80-year-old, the blood pressure is 160 by 80 or 160 by 70 or 170 by 50. So what is your drug of choice? Is having isolated systolic hypertension. The systolic blood pressure is 160 or 170, but the diastolic is 70 or 80 or 90, etc. Less than the 90. So two drugs. One is calcium channel blocker. Second one is diuretic, like endopamide. Endopamide is a metabolically safe diuretic is the endopamide. See, isolated systolic hypertension, I already told you, the African origin. Other possible, elderly and also the angina. Here you can use the diltiazem, calcium channel blocker, unstable angina, etc. Prinzmetal's angina, vasospastic angina. There you can use the diltiazem. Side effects, pedal edema at higher dosages, headache and tachycardia because it is a vasodilator. Calcium channel blockers are the vasodilators. So these vasodilators will have a side effect of headache, tachycardia and pedal edema. Then the diuretics. What is the compelling indication for the diuretics? Isolated systolic hypertension and also edematous conditions like heart failure. Okay. So what is the contraindication for the diuretics? Pregnancy and gout. ఇప్పుడే కదా చెప్పుకున్నాం ప్రెగ్నెన్సీ కాంట్రాఇండికేషన్ డైరెటిక్స్ అండ్ ఏస్ ఇన్హిబిటర్స్ అని వాడేమో ప్రెగ్నెన్సీ కాంట్రాఇండి ఏస్లో చెప్పాడు ఇక్కడేమో డైరెటిక్స్లో చెప్పడం లే యూ హ్యావ్ టు యాడ్ ఇట్ ఓకే ప్రెగ్నెన్సీ డూ యూజ్ డైరెటిక్స్ నో గౌట్ అగైన్ నో సో గౌట్ అండ్ ప్రెగ్నెన్సీ ఆర్ కాంట్రాఇండికేషన్ ఫర్ యువర్ diuretics. What are the side effects? So obviously hyponatremia, maybe hypokalemia, hypomagnesemia, etc. Electrolyte imbalance. So metabolic, hypokalemia, hyperglycemia, hyperuricemia, low dose minimizes the metabolic effects. Then the beta blockers. What are the compelling indications for the beta blockers? Again in the cardiology postings, metoprolol, metexel, 12.5, 12.25, 50. So that is a metoprolol. Or maybe your Conquer, 1.25 mg or 2.5 mg, bisoprolol. So a compelling indication is the post myocardial infarction, post PTCA, post CABG. All the cardiologists, though, their favorite drug is your metoprolol or beta blocker like carvedilol and sometimes, or maybe your bisoprolol. So beta blocker is a must for all these three: MI, angina, and heart failures. What are the precautions? cautions in peripheral vascular disease. So beta blockers are contraindicated in peripheral vascular disease, like your atenolol or your metoprolol or your propranolol. But a vasodilatory beta blockers like carvedilol and bisoprolol can be safely used in peripheral vascular disease. In the same way, they caution the diabetes. So diabetes is not a contraindication to use beta blockers. We use the beta blockers. That is, selective beta blockers can be used in the diabetics also. Contraindications, asthma. Again, in the asthma and COPD also, you can use the beta blockers. So, and heart blocks, yes, beta blockers are contraindicated. Fatigue, reduced exercise tolerance, hyperglycemia, especially when combined with the diuretics. Alpha blockers. Indication is BPH, your losartan. So, will have a uricogenic effect. CHF, postural hypertension, be cautious, and contraindication incontinence. Aldosterone antagonists, your spironolactone. Conn syndrome and resistant hypertension. So, resistant hypertension, there is a role of spironolactone. And possible in heart failures also. Cautions. So, in the heart failure, now you have the 4 pillars in the management of the heart failure. So, one pillar is your ARNI, second pillar is your beta blocker, third one is mineralocorticoid receptor antagonist like your spironolactone or finerenone. And then the fourth pillar is SGLT2 inhibitors like DAPA and EMPA. So, these are all the different contraindications. So, these are the very important slides, shows you the indications, the contraindications, the side effects of the commonly used antihypertensive medications. So, comorbidities. Take into account the comorbidities while choosing an antihypertensive drug. Beta blockers in the heart failure and asymptomatic coronary artery disease. ACE inhibitors in the heart failure and the diabetes mellitus and also the nephropathy or proteinuria. Recommendation of the JNC 8 guidelines. If goal BP cannot be reached using half the dose of the 2 drugs, sequentially maximize the dose of the 2 drugs. So, straight away they said that use the 2 drugs, dual therapy at a lower dosages. Suppose if you want to use the telmisartan and the amlodipine, the telmisartan maximum dose is 80 mg and the amlodipine maximum dose is 10 mg. So, you can use 40/5 or you may be 20/2.5. So, that is the lower doses also can be used, safely used, rather than going for the single drug alone. If still not uncontrolled, consider adding the third class of the drugs. So, you can add the third drug like a diuretic, calcium channel blocker and sartan is the most favorable triple drug therapy nowadays antihypertensive medication. Your Telma Trio or Telma DH or Telma ACT. Okay, so that means your telmisartan plus amlodipine plus diuretic or telmisartan plus cilindipine plus diuretic. So, advantage of the combination therapy. Combination therapy 5 times more effective than increasing the dose of the first drug. That is the most important take home message. Instead of increasing the one dose, suppose the patient is getting one amlodipine from 5 mg, still the patient is hypertensive, you have the 2 choices. One, you can go to 10 milligrams of the amlodipine or you can add the telmisartan 40 milligrams. So, adding a telmisartan 40 milligrams to the amlodipine 5 milligrams is 5 times more effective than increasing the dose of the first drug. For a single CHD event or a stroke prevented by doubling the dose of the single drug, 4 such events should be prevented by using the combination therapy. Advantages: it improves the tolerability. Lower doses in combination minimizes the side effects, that is a very important. Synergetic effect, very few side effects. Side effects associated with the one agent are neutralized by the pharmacological properties of the second drug. So, the most favorable antihypertensive in the rural area is amlodipine plus atenolol. So, amlodipine causes tachycardia, atenolol causes bradycardia. So, that will be the nullified. Okay. So, this is the side effect of one drug will be neutralized by the side effect of the other drug. Associated with a better long-term blood pressure control if the patient is on a dual therapy. Combination therapy enhances the adherence to the therapy. With a single pill, he is taking the 2 drugs. Promptly achieves the BP goal, helps reducing both the number as well as the frequency of the dosing. So, things to keep in mind about the combinations. Preferred drug combinations: calcium channel blocker plus ACE or ARB, ACE or ARB plus the diuretics, calcium channel blockers plus the diuretics. Beta blockers plus diuretics should not be used in combination therapy due to their metabolical side effects. Okay. So beta blockers with high metabolic side effects is atenolol, metoprolol, etc. Beta blockers with low metabolic side effects is bisoprolol. In the same way, diuretics with high metabolic side effects, your clothiazide, etc., or your loop diuretics, or your spironolactone. Whereas the diuretic with very least metabolic side effect is indapamide. So in that way, you can combine these drugs. Otherwise, in general, beta blockers and diuretics are metabolically not friendly agents. How long should we go? So I answered, lower is the better. So reach the target from 120 to maybe 120, 130, not more than 140. That should be your target. So there is a New England Journal of Medicine editorial. Clearly, the current concept of hypertension is insufficient to determine who benefits from blood pressure lowering or how far to lower the blood pressure. Sprint study strongly supports the pharmacotherapy decisions based on the absolute risk levels in a similar way to current recommendations for the lipid lowering. Sprint redefines blood pressure target goals and challenges us to improve the blood pressure management. So Sprint study says that systolic should be not more than 120. So your goal of systolic should be around 120. That's what the Sprint study shows. Challenges in sustaining the targets. Physician's inertia. So this is our inertia. We don't know that hypertension is a very big topic. We don't know the pathophysiology of hypertension. What we know is just the representatives are saying that you use that drug, this drug, that only we remember. So with that knowledge, so obviously you are very, very poor candidate to prescribe a good antihypertensive medications. So who is at fault? Sustaining the targets? So all of us. So improve your hypertension knowledge. So therapeutic inertia has been defined as the failure of the healthcare provider, failure of the physicians, failure of the postgraduates to initiate or intensify the therapy when the therapeutic goals are not reached. You need not ask your professor or assistant professor, etc., etc. When the fellow's goal is not reached, you use your knowledge and improve the drugs or escalate the drugs. It is regarded as a major cause of uncontrolled hypertension. So the major cause of uncontrolled hypertension is our inertia. Drug adherence is very poor. Patient involvement, so that is also very important. Follow-up is very important. Monitoring is very important. So how to overcome the obstacles for inadequate BP control? Use non-drug methods. Use high drug dosages. Use the right drugs and right combinations. Use more drugs but few tablets. That means the combination use so that the compliance will be good. Encourage the patient involvement in the management of the hypertension. So ask yourself to the patient, what is your goal? So if the BP is not under control, what will be the complications? So these are all you have to educate the patient. So the take home message, initiate the pharmacotherapy based on the stage of the hypertension, that is a stage 1 or stage 2 or stage 3, and absolute risk individual for the CV event. Primary goal is achieve the BP control, 120/80. Choice of antihypertensive is important, but secondary to control the BP. Choice of drug depends on the coexisting conditions. So current goals less than 140/90 in all less than 80 years of the age group. When the more than the 80 years of the age group, it is 150/90. New Sprint study shows that the systolic should be around 120. Long-term drug adherence is very, very important. That is very important. Long-term drug adherence is very important. Patient education is critical to achieve this goal. So stop here. Thank you.